emergency exit focuses on the frustration patients who need emergency medical care or attention sometimes go through. You would also see how some referral hospitals frustrate the efforts of ambulance drivers to the point that they hold up their trolleys as best to treat patients. This is the second of the 4-part series on the AM show this week on services provided by the Ghana Ambulance Service.
Due to this inadequacy of ambulances, many stations have been collapsed, leaving a few to cover the country.
The other thing is that currently there are many districts which still don't have the system yet. So we are still gradually increasing. But the reason we always prefer to look at the cup half full and not half empty is that from a humble beginning of nothing, we have 130 stations. From a humble beginning of just 57 staff, now we have 1,700. Initially, we were doing our training at the Fire Academy and Training School. Fortunately, now we have our own paramedic and emergency care training school. Good. Exactly, at King Council in Ashanti region, where we now solely do training for paramedics. And it's also in future supposed to be a facility where doctors, nurses can go for short courses as refresher programs in emergency care to equip themselves and to improve their skills.
Okay. So you've said a lot, but when we're talking about the fleet, every 5 years you need to, how many do we have now?
Currently we have 160.
160? 130 stations.
Absolutely.
Where are they now? Where are they?
In Ashanti, in every region has the distribution, because Ashanti we have about 17 stations. Greater Accra we have about 17 stations.
Those are the largest, I guess.
Exactly. The rest have 16, some have 14, some have 11, some have 10. So it's distributed across the country.
Now, what goes into considering how many stations you have? I know Accra has a very large population, so that may be a factor, but do you consider accidents?
Absolutely. When we started, the first early criteria was accident-prone areas. Okay. And then it wasn't long, we realized that there are communities in the rural areas didn't have accidents, but they had a lot of high mortality of maternal cases. Okay. And therefore, we had to revise the accident proneness to include places where you had high mortality or high maternal mortality. Okay. Now, even after the criteria, it was obvious and it became evident that every community really deserved the presence of a pre-hospital emergency care system. So now the plan is to expand to cover every district capital.
So ideally, how many stations? You say we have 130. How many should we have?
Oh, we should have more than 500.
Wow.
Yes, we should have more than 500. Because if you look at the population of 27 million, definitely even the 500 is woefully inadequate.
Wow. Okay, so when we have them and they are placed there, what is the mode of operation?
Okay, the mode of operation is simple. First of all, every ambulance station is manned by a crew of paramedics or emergency medical technicians. There are normally 3, a driver EMT and 2 non-driver EMTs. Okay. And so when there is an emergency in the community, for example, the call will always go to the dispatch center, and our emergency code is 193.
To bridge this gap, many people in their time of emergency don't even bother to reach out to the ambulance service. A commercial or in some cases private vehicles are the alternatives. On one of my rounds in the course of putting together the story, I met this family at the Kolebu Teaching Hospital. It was past 9 p.m. on a Friday evening. This woman has brought her critically ill son to the Premier Hospital for attention. Unfortunately, she was greeted with a no-bed response. She was asked to go to the Greater Accra Regional Hospital, but there too, she was told there was no bed to admit her son. Not even her pleas would touch the heart of health officials. She has returned to Kolebu with her son to plead for his admission, and the taxi driver, who has been patient for the last 2.5 hours, cannot continue to do this favor because he is certain this woman cannot pay his fare even if he charges per the time and rounds he's done. On her return to Kolebu, she was met by a security man and a nurse and told to take her sick son elsewhere. After desperate pleas, she was advised to go to the Cocoa Clinic if she can afford to pay.
I came here earlier with my son and they told me to go to Ridge Hospital. We gone there and they said they have no bed. Now I am back here and they are telling me to go back to Ridge, or if I have money, I should go to Koko Clinic.
The story ended in disappointment as the family of the ill man moved to seek help, only God knows from where. The taxi driver situation could have been the fate of an ambulance team dispatched to the home of this family, if there was one available at all. According to the Ghana Ambulance Service, the lack of bed syndrome by referral hospitals and sometimes inadequate preparations make transfer of patients complex.
Ideally, unless of course it's outside the hospital, if it is inter-hospital transfer, the ideal situation is that the doctor that wants to refer has to get in touch with his colleague, discuss the case, and then the doctor will give him green light to transfer the case. That's the normal thing. And you should have reasons why you are doing the transfer. We have different categories of transfer. Some may be due to lack of the skills, some may be due to lack of the facility, and others may be due to absence of certain equipment. So when you have convinced yourself that there's a need to do the transfer, then you communicate with your colleague. When the arrangement is done and it's now left with the transportation, that's when the ambulance service comes in. But most often than not, in our setup, they don't do the arrangement. They just refer and then they call the ambulance service. Then they take the case and they realize they arrive there and then there is no bed. So we will really want to take opportunity to appeal to our colleagues. When you want to make any referral to another facility, it's better to make efforts, contact, make arrangements, and when everything is set, then you move. Most often, it's in the interest of the patient for the arrangement to be done. If you don't do that, you take the patient, leave, and then the bed is released, and then they get to the next level and there's no bed. By the time the patient comes back, the bed has been utilized or used, and that can really create inconveniences.
Any other challenge?
Because the next challenge will be with the receiving hospitals, especially when one hospital is referring a case from the other end. Let me say, Lajino is referring a case to Kolebu. They are supposed to do arrangements. Lajino is supposed to call Kolebu and then tell them, I'm referring such case to your end. And then Kolebu will prepare for a bed or a doctor to attend to the patient. Most of the time, they will call and then they will tell you they've made all the necessary arrangements. You can call the receiving end. They will tell you, yes, we have received a call from them, but we can't assure you of the bed.
Really?
Sometimes they will tell you, oh, you come, we are aware. The ambulance will get there, and the only thing they will tell you, they don't have bed. So they have to detain the ambulance trolley. We have to leave the patient on the trolley. And when it comes like that, it becomes very difficult. When another hospital is calling, or there is another accident somewhere, an emergency somewhere, and then we have to dispatch, sometimes we end up, most of our ambulances will be there without trolleys because our trolleys has been detained at the receiving end.
Because they claim they don't have a bed.
Because they claim they don't have bed. And then we can't take looking at the patient condition, there's no way you send the patient back to where you took the patient from. So the best thing to do is to leave the patient on the trolley at the receiving end so that they can attend to the patient.
What do you
Both
do
the receiving and the referral, the receiving facilities.
Somewhere.
Yes, we can't do them anything.
Really? Then they continue doing that.
And that is what they have been doing for years. Hello. When the ambulance crew gets to the receiving end, instead of either the nurse or the doctor to attend to the patient, they are now going to send the ambulance crew to go and make folder, to go and do maybe lab tests and other things before they will tell you they are ready to accept the patient. So if we've not done all those things, then the patient will be in the ambulance. And then when it comes like that and there's an emergency, we find it difficult to, as I'm talking now, an ambulance is at Kolebu for almost 2 hours now. We are finding it difficult to hand over the patient to the hospital authorities. Meanwhile, the caller called and they said they've made all the necessary arrangements at Kolebu. So the ambulance have to come, and then they got there, and it's like they said they are not aware. Most of the time, some of the doctors and the nurses, if they want to refer cases, instead of them calling the exact department that they are referring the cases to, they can call a colleague doctor, a colleague nurse that they know that, oh, maybe Naomi is at Kolebu, so let me call Naomi. Then he or she calls Naomi. Naomi, we have a case there we want to bring to Kolebu. Then Naomi will say, oh, you come. Naomi will take the call. Instead of Naomi going to the department that the patient should be sent to go and inform them, to make inquiries, Naomi will not do that. So at the end of the day, we will call the person, and then, oh, we are aware, you bring the patient. When you come, you are finding any difficulties, you call me. And then to our surprise, the moment they get there, the person's phone will be off. So at the end of the day, the patients become the problem of the ambulance crew.
So I witnessed one of such complex situations at a Kolebu Teaching Hospital when a case was referred from the Pantang ambulance substation. It was one of the few cases where the hospital referring the patient made adequate preparation at the receiving hospital. But upon arrival of a team, they were informed the situation has changed. What ensued was really unexpected.
We were dispatched for an emergency at Legon Hospital. So after picking the patient and coming to the referring hospital, that's Kolebu, they told us the arrangement they had made and the bed that was reserved for us had been given to somebody just 10 minutes before we got here. So we would have to wait 2 or 3 hours for them to find another bed before they would release our stretcher for us. So we had to keep our stretcher here for the 3 hours that they would keep it until they get a bed before we can go. So we'd have to wait for all that time before we can go.
So tell me, how does this affect your work today?
Well, it gets very tedious because most of the ambulances around my vicinity where I cover are broken down, and I cover all the area. So at a particular time when we are supposed to be here, or you're supposed to be going for other cases, we are supposed to waste all that time here until we're able to get our trolley before we get back to base. And for for all that time duration, other people might be wanting the service of the ambulance, which is parked here, and so we're able to get our trolley.
You've relayed this information to the control room that you are unavailable within this period because you are waiting to get your trolley. Why can't you just leave the trolley and go?
The trolley is it's very important because it's what you use to carry the patient. So without it, you can't work, because when you carry the patient, you can't leave the patient on the stand. You need a trolley to keep the patient on before you can do other stuff. It's one of the most important things in the car. Without the trolley, the ambulance is nothing. Like it's empty.
After several checks to find out if the trolley could be freed for the EMS team to attend to other cases, but to no avail, they called the control room to relay the information.
They might get a bed from the trolley bar, so they are waiting after maybe 10 to 15 minutes, we will go there and see if they can get it for us. Okay.
After more than 2.5 hours of waiting, the team had no choice but to leave the trolley at the hospital. We've been waiting for 2 hours, 20 minutes, and one of the EMT personnel has gone to check on the trolley. So he has an update for us. Tell me, what did you find?
Yeah, when we went there to check on the patient and then the trolley, we were. I was told that by one of the doctors that still the trolley is not ready. They were expecting a patient to recover within these 2 hours. That is why he gave us the time 2 hours. But the patient was not recovered. Was not recovering. So you are just in. You don't know how to do.
So you are going to wait for how many more hours?
She didn't give us any specific hour to wait. So we, like 30 minutes, we'll go back. If it's not ready, then we call control and see what we can do.
Amazing. We just showed you some of the frustrations that the operators of the ambulance service go through, you know, when they are transferring patients to the facilities. And this is a referral to no other place than Kolebu Teaching Hospital. And you saw how in that piece, trolleys carrying patients are not immediately returned. We're talking about after waiting for 2 hours and over. But that's not all. Martha Krenzel Aqua has been putting the spotlight on the operations of the ambulance service, including the frustrations that we just brought to you. We started yesterday, continued today. We'll bring you another piece tomorrow. We're ending on Friday. So you stay glued and make sure you don't miss any of the episodes.